Hey everybody, it's Erik, co-founder, partner of Village Global, a network-driven venture firm. And this is Venture Stories, a podcast covering topics relating to tech and business with world-leading experts. Hey everybody, welcome to another episode of Village Global's Venture Stories. I'm here today with the very special returning guest, fan favorite, Nikhil Krishnan. Nikhil is the founder of Out of Pocket. Nikhil, welcome back to the show.
Thanks, Erik. If I'm a fan favorite, your only listeners must be my parents, because I don't think any of the fans are requesting this.
Exactly. I'm sorry, everybody.
Exactly.
Okay. Nikhil is back. Since you've been here over a year ago, you founded Out of Pocket. Why don't you introduce us to what is Out of Pocket and what are your goals and aspirations for it?
Yeah, sure. So Out of Pocket is basically, for me, it's the intersection of healthcare and comedy. And really what I'm trying to do is make it easier for people to understand how the business of healthcare works. So that sort of has taken on a few different forms. So I write a newsletter at outofpocket.health. I'll be releasing a paid version of the newsletter soon. And I'm working on crash courses on the industry. So intensives on how things like a clinical trial works or how a insurance claim gets processed, et cetera. And then also actually coming out with kind of random novelty products that explain how healthcare works. So I wrote a children's book about how clinical trials work. I am working on something exciting, which is TBD, that hopefully will come out the next month, but I don't want to spoil too much. But basically more things to kind of get people familiar with how healthcare works, and just sort of excited to potentially come work in the space and fix some of the problems that exist. I think healthcare is just sort of notoriously confusing and opaque for a lot of people, and I don't think it has to be, and I'm trying to work to make that more accessible.
I'm personally, as a fan, I'm just excited for the mixtape to come out.
Oh, you have no idea. It's called prior auths and denials or something like that. I'm trying to think of that. I'll think of the name.
Love it. So I want to go through some of the topics today you've gone through, and really just around a variety of different topics in healthcare as you've approached it, from an analyst, from an operator in the space, from an investor now in the space. You have your own investing practice. The first one I want to get into is employer-based healthcare. You sort of did this deep dive, even just sort of on the history of how it became employer-based to begin with, and sort of the challenges that have come from that, and potential changes we could potentially make. Why don't you give some of the historical background?
Sure. Yeah. So for those that don't know, the U.S. is actually one of the only developed countries in the world that has employers pick your healthcare plans for you. It's like a very unique thing. America is unique in so many different ways, and this is like one of the worst ways. But basically, after World War II, in order to stop wage inflation, the government basically prevented companies from raising wages past a certain point, but basically said, hey, listen, you can't raise wages, but you can give other benefits if you want to basically better compensate employees. And so at the time, healthcare was not a very expensive. Getting healthcare services was very expensive. So it was one of those things that companies basically offer to their employees. But then what happened was, basically, because they couldn't raise wages, a lot of these companies said, hey, why don't we just give better health benefits? And this is compounded by the fact that also around the same time, the government basically decided that employers could essentially put pre-tax dollars towards those health insurance premiums. Again, this shouldn't have been a huge deal, because at the time, health services were not expensive. This was sort of like a rounding error for most businesses, et cetera. But that basically exploded this entire industry of employer-sponsored healthcare, where your employer picks the health plan that they think the employee should have. They can route pre-tax dollars into that health plan, and people basically now depend on their employers to get their health benefits. And I think right now you really see the glaring flaws in that problem, where millions and millions of people who are now furloughed or getting fired from their jobs or having to close down simply just don't have good health insurance anymore. I mean, even for me personally, when I left my job, I had the option of basically continuing my employer healthcare coverage through something called Cobra. And what that means is you could have the same plan, but you'd have to basically make up the portion of the spend that your employer was covering for you when you were working there. And, that was like 75-80% of the dollars. I'm like, whoa, I cannot pay like $600-$700 a month for this plan. That's wild. I'm lucky because I'm under 30. So you can get something called catastrophic health care, which is a catastrophic health insurance coverage, which is relatively cheap. But like if I was trying to start a business and I had to, pay those health insurance premiums after I left, like there's just no way. Like that would have been a huge problem.
Talk about why it's what changes you wish could happen here in the regulatory perspective, and why they've been so hard to change.
There are like a lot of different ways you can think about decoupling this, and both political parties should actually be on board with changing this, because it's both ruining any sort of free market semblance and also making things extremely expensive. There's a few ways you can approach this. There's some stopgap measures. So if anyone ever remembers, there was this thing called the Cadillac tax, which is part of the Affordable Care Act, which was basically saying, hey, if you offer too lavish of health benefits to employees, we're basically going to tax you, above a certain amount. That sort of never really got anywhere. So that's kind of been killed. I think maybe it's getting pushed out. I'm not actually totally sure. Another way to change this, which, there are some developments here, and I think OnDeck is actually working with a company called Savvy, which is doing some of this. So it'd be interesting to hear kind of how you're working together. But there's just something called ICHRA, ICHRA, which basically allow employers to give those tax benefited dollars to employees directly so that they can go and shop for their own health insurance themselves, as opposed to the employer picking health insurance plans for them. And what that does is basically say like, hey, listen, employee, you take the money and you basically pick a plan on the individual market that you think makes the most sense for you. Because then if an employee changes to a different job or something, whatever, they can potentially still pick that same plan later and stick with it. So now insurers actually become a little bit more competitive, trying to make sure you actually stay on their plan as you jump from job to job. So those are some things that have sort of been proposed. There are other versions of this which are like, hey, what if we have a public option insurance plan on the individual exchanges, so that if I'm at a job now, I can look at the health insurance plans that my employer offers versus maybe something cheaper, affordable on the individual exchanges, and then actually compare which one makes the most sense. The most extreme version would be like, what if we just had Medicare for all and we just didn't have any employers' involvement at all? So there are different proposals on how to fix this. I just think one of them needs to go forward. I think the problem is everything gets kind of stuck in gridlock once it's proposed. I mean, as you can imagine, large employers don't exactly want to give up these lavish health benefits because it's a great way to attract and retain employees and stay competitive in the labor marketplace. But societally, I think it's really messing things up. So I think we really have to change things.
Yeah. And you made some comparisons to England in the piece, but why don't you talk a little bit about just sort of to the extent that you've studied international health systems and what the sort of different approaches or different strategies are, or different learnings that we could potentially, or lessons that we could potentially take from them?
Yeah, totally. I'm definitely not an expert in international healthcare by any means. So I take everything I say with a grain of salt. But, you can look at the UK and the NHS that they have. A lot of people like to compare Singapore, et cetera. There are a few things that are probably just worth noting. One of the things that the US sort of lacks that I think a lot of other countries has, we don't have a great, publicly run healthcare system. So all of the hospitals, all the care providers, et cetera, are in some capacity part of the private sector, or, they're nonprofits, but nonprofits ? Which we can go into if you want. But, a lot of these other countries have government run health systems, which makes it way easier basically to have a public, both a public health insurance plan and a public care option. And as well as for people who want to pay more, they can get access to private more private sector amenities, etc. I don't think the U.S. has a great government-run option right now, which makes it difficult, especially on the hospital and provider side. Things really non-competitive. So that's why if you look at a lot of geographies, they're concentrated to one or two health systems, providers, etc. Because and they basically have pricing power monopoly because there's really no competition for them. That being said, it's like I think one of the reasons a lot of other countries can do that is because there's a lot of trust in their government and in their public institutions to run these effectively. I don't know if the U.S. has that same level of trust. And it's also worth noting that most of these companies built their healthcare systems at a time where they had some sort of like dictator or faux dictator, basically, who could just make these calls and get these things built. I'm not totally sure. In the U.S., we have such a bipartisan system, which has its pros and its cons. But things just happen way more slowly here if we wanted to actually do a massive overhaul like that. And the only other thing I'll say is, again, a lot of these in these other countries, it's funded by either higher taxes on individuals or on businesses, and I think the U.S. has struggled a lot with that. And then the only other last thing I'll say is that for most countries, a lot of them will actually still do end up sending their complex care patients who have complex care end up coming to the U.S. for the quote unquote best care. I think the U.S. does a great job actually when it comes to really tough disease areas, rare disease areas, etc. We really do, I think, have some of the best care in the world for things like that. But the trade-off is that for kind of regular care for people, it's extremely we have a really kind of backward system that's extremely expensive.
Yeah. And I've heard the critique that we basically have like the worst of sort of this hybrid private public sort of model. And maybe Singapore is an example of a country, obviously significantly smaller, but that maybe that has some of the best of sort of a private public hybrid.
Yeah, totally. Yeah. And actually just to riff off that point, it is worth noting that like, I don't know how many other countries have this geographic spread that we do. I think this is sort of kind of an understated point, is that a lot of the US's healthcare issues also stem from the fact that we just have really tough rural health care delivery problems. It's just hard, just think about like this landmass that is the US. It's hard to get people in these kind of hard to reach areas access to good healthcare. We have problems basically having access to like for groceries and food, and their food deserts kind of rampant there. So, I think the density / rural aspect of this is not to be understated. To go to the private and public health kind of best of both worlds thing. Yeah, I mean, the problem is like we have a system that is currently in a lot of examples hindered by regulations, like by some sort of government opposition. I think we see this in some parts of tech, but I think in healthcare it's very apparent where when you add more and more kind of reporting burden or documentation burden or kind of just like things you need for compliance, it just sort of ends up favoring large players versus small ones. And so it's actually really difficult to start a healthcare business in a lot of areas, especially, for example, in private practice or anything on the care delivery side, because a combination of regulatory issues, like, for example, there's something called, in some states, they have these things called certificate of need laws, where you have to like prove to the state that, you need a new MRI system because there aren't enough in the state. Like, that's just so non-competitive and so difficult. If for example, you want to take part in some of these new government bundles to get reimbursement in new ways, like most of these smaller practices just don't have the ability to do that. And that's kind of why I think over the last 10 years or so, you've just seen all of the small, medium businesses in most parts of healthcare just kind of get swallowed up by the large ones. So on the regulatory side, it's become very, I think there's a lot of barriers to new entrants coming in. And then on the kind of free market pure capitalist side, I think it's really, really tough because a lot of these extremely large players have become pseudo monopolies that can just kind of milk the system for everything it's worth. And I don't know, there's just like so many middleman entities that are just trying as much as possible to like squeeze every penny out of the healthcare system. And there's no real competitive force that would kind of force them to price lower or force them to, care about things like customer acquisition or normal things in which businesses need, like normal businesses and other industries need to think about. There's just no real competitive forces that would force them to drive down the price. And so you have this like bad duo of no room for new entrants, no government, no actual like government negotiating. Like I think in a lot of other countries, you have some sort of government entity who does kind of broad scale negotiating of prices for a lot of entities. You don't really have that in the US. And then you also have no real competition happening. So you have these players who can kind of just squeeze as much as they can out of the system. So kind of a long rant, but I think there are good ways to do it. There are way to do it.
and do you think that, election year, COVID, like, do you think that now is a likely opportunity that we'll see some real changes? Like, what do you expect our conversation in 6 months to be?
Oh my God. Listen, if it doesn't change now, I don't know when it's going to change. Like, it's this combination of, you have a global pandemic. Healthcare is like, the number 2 issue for all voters. Number 1 is economy, which I don't even count because that's just like life. So healthcare is almost the number 1 issue for everybody. You have an election year happening where people are like really trying to find someone who's going to bring serious change to the system. I just think it can't go forward the same way it is currently. I wish the US was a little bit better at just experimenting with new models generally. And I think COVID is actually the first time that is like everything's really shaken up and there's no like default player to turn to anymore on like, hey, like we have this problem, like let's just renew our contract with X and it'll take care of it. It's like, oh, we have like a whole new set of problems now. There's no established player that has expertise in this area. So we're open to kind of new suggestions and new models, etc. And also, it's interesting, I think right now we're running naturally running a lot of parallel experiments anyway. Each state is basically taking a different approach to how they're handling COVID. Each country is taking a totally different approach. So I think at the end of this, you'll actually have a lot of data to support doubling down on different experiments or initiatives depending on how different geographies turn out. So it'll be interesting to see. I mean, on the investing side, at least, I look at pre-seed and seed stage companies, and I've just never seen more kind of excitement to build stuff in healthcare or like take advantage of some kind of new openings that have been created thanks to COVID. Or simultaneously, like I've never seen this many non-healthcare people interested in healthcare, which I think is a good barometer of just like the number of smart people that seem to be entering the space right now is so high that I would be shocked if you didn't see a lot of really exciting companies built, starting today.
Let's segue into your investing thesis. How do you think about types of companies that you're excited about, or subspaces, or things that are sort of newly enabled or empowered because of COVID, or just where we're at right now in 2020?
Yeah, totally. I mean, I think it kind of falls into a few buckets. One thing I sort of mentioned is that I think healthcare has sort of lacked these small, medium-sized businesses across different parts of the industry. And I'm really looking for a lot of companies that make it easier to sort of build out small, medium businesses. So really like Shopify for X across healthcare, and have been looking at a lot of companies that do this for primary care, for different types of specialties, doing it for pharmacies, like anything that sort of enables more competition in the space by making it easier to start up a business is one area that I'm really kind of bullish on going forward. Another area is also just diagnostics generally. I think the way care is delivered today is going to change quite a bit because we're going to move from this reactive healthcare system where you basically feel sick and then you go see a doctor and they do some tests, tell you what's wrong, and that's sort of V1. I think V2 is we should be alerted before we actually feel symptoms, because that's in a lot of cases too late. We should be alerted to when that happens, so that someone can reach out to us and say like, hey, noticed you have some abnormal readings, wanted to just sort of check in, etc. And so when you sort of change how care is delivered by moving from reactive to proactive, you can build entirely new kind of care delivery pathways and really rethink kind of how people should be receiving care. And, that also changes where care is actually delivered, right? Like, I think right now you're seeing so much excitement over things like home care and care delivered in areas that maybe are not traditionally healthcare areas, like your grocery store, your pharmacy, et cetera. You can actually bring care to new areas if you make the diagnostic tools better. So really excited about the diagnostic space generally. And then another area that I'm looking more towards is kind of these services as APIs. So really, how do you make it easier to start other healthcare companies, just generally? So, TruePill, I think, and Wheel and a lot of these other companies, which are taking these kind of commoditized services and making them so easy that you can kind of just plug them into whatever your healthcare flow is for other digital health companies. I think that's going to be really exciting going forward, especially as all these new companies are getting built. So, very excited about these kind of enabling companies that will enable new digital health companies to spin up. And also just fraud. I think we're in the golden age of fraud right now. Like there's so much money just sort of floating around that it feels like almost every other day I'm reading about some like $1 billion healthcare fraud that's, actually seemingly simple to detect. It's just, it's no one's really done it. So, I think companies that have some fraud specific use case, I'm really interested in. So looking at those buckets broadly, but honestly, I'm excited about so many new things after talking with people that even since I wrote out my investing thesis, a lot of that has changed even just in 3 months. I've never really seen healthcare move this fast. So, it's crazy. Just I'm getting like whiplash, just like reading new decks and stuff.
Totally. You had this tweet around the stages of building a healthcare company. Sort of, I think it was the grief. I'm trying to remember exactly how you phrased.
6 stages of healthcare grief. My faux Sigmund Freud of companies.
Exactly. Sort of, and it sort of traced this curve of we can build a platform that connects all healthcare to let's build I'll have you walk through the 6 stages and then on a high level, and then let's get to each of them one-on-one.
Sure. Yeah. So I mean, I think I've just seen so many people go through this process that I was like, let me just write this. If anyone listening has ever read Chris Dixon's original post about the idea maze, or a lot of follow-ups to that post, but I think this is sort of the healthcare version of the idea maze, where a lot of people, I think, go through a very similar path where they start at, let's pay people to be healthy. And, they're like, the problem with healthcare is that, you can actually save money long-term if you pay people smaller amounts to be healthy behaviors early. That's always where they start. The second becomes, that the problem is actually that there aren't any good healthcare databases or electronic medical records. All of them are really old. Hospital, they're built in like the 90s on like mumps and like all these ancient programming languages. Like, patients don't have access or like the ability to give the data wherever they want. Like, that's the problem. We need to fix that. And then everyone's like, shit, healthcare is really hard. Like I'm kind of jaded at this point, yada, yada, yada. And so now they're like, okay, people won't pay for this personal health record, but all these employers have to handle their employee spend. So why don't we target the employers and help them manage the healthcare of their employees? So that's like stage 3. Stage 4, now they're like, wow, healthcare sucks. I'm just not gonna like do this anymore. Like, why don't I just go do some easier thing? I'll go like start a CPG company. No offense to CPG companies. And then the phase after that, they're like, okay. Let's like start incremental. We'll just make one of these existing processes 5% better. We'll just make it a little bit better with software. We'll just like write a few scripts, etc. We can start there. That's like a good wedge that we can go to the bigger problems. And then at a certain point, they realize, the only way that I can either actually like change the healthcare system is by delivering services myself, whether that's like we're going to deliver, we're actually going to deliver care ourselves, or we're going to transport goods ourselves, or we're going to basically have like a consulting services arm to onboard new clients and offer talent ourselves, etc. They realize that like, services are actually a really important component of the business. We can't just be like a software only platform. And then that's like the 6 stages. And, people learn this either within like 6 months or sometimes 6 years. So I think I just wanted to write it out because I was like, I've heard this enough times at this point. This is what a lot of people think about. So let me just lay out the common. You're not the only one to go through this if you go through it.
Like, what time does this save in the sense of like for people who learn about these stages and understand it? Like, how does that change their trajectory? Like, what mistakes will they avoid?
I think for a lot of people, it's like I think the main thing is when you start noticing the problems outlined actually come up, then you know that like, oh, okay, this is actually like something that has been either tackled before or people have confronted. So there are resources to basically either address this issue, or we can kind of keep moving forward and go through this process, I would say, faster, or even in parallel. You know, some people might try to build like consumer and enterprise products now at the same time and just see which layer stick. Or, you know, the part I would be more excited about is people kind of jumping straight to the services part. I think rather than try and kind of do this like experiment, iterate on like small software fixes, etc., really try and swing for the fences from the outset. And, you know, part of this, I think, is where venture investors have to also get a little bit more comfortable with healthcare companies is understanding that, listen, a lot of the big businesses that are built in healthcare in kind of whatever this era of digital health are companies that have a large services component to them. So this post is not only, or the series is not only meant to help entrepreneurs kind of navigate these waters. I think it's also meant to make investors a little bit more comfortable with the idea that there are going to be businesses that look a little bit more like services companies that are competitive with the existing healthcare system. You know, maybe it's intimidating to like start a new whatever insurer, et cetera, but that it's actually, I think, one of the best ways to build a big business. So, you know, it's trying to sort of, I think, just get entrepreneurs and investors a little bit more on the same page.
Totally. One of the things you wrote about in your investment thesis post is unbundling of hospitals. Uh-huh. And you also wrote a separate piece about how sort of nonprofit hospitals are the most, you know, profitable enterprises. Why don't you talk about sort of both of those dynamics and shed some light on them?
Yeah. So, you know, it's funny. It's like, I think everyone likes to yell at different entities in healthcare, but the people that have like slid, I think, most under the radar over the last 10 years are hospitals who have basically just been buying up all the smaller hospitals in their areas and kind of building these local monopolies, essentially, which let them price kind of whatever they want. So, you know, I think and if you look at like where the cost of healthcare is, most of it is actually our services and delivery of healthcare. So, you know, if we want to decrease healthcare spend in the country, one thing we really do have to look at is how is care delivered and why is it so expensive, how we do it. And one of like many aspects of that is that hospitals have just gotten extremely big and non-competitive in a lot of these geographies. And one thing that's like, one interesting dynamic is that a lot of these hospitals are quote unquote nonprofits. And what that sort of means in reality is that a lot of these hospitals actually, they just reinvest a lot of the capital that they have into expansion, new buildings, et cetera. And also a lot of them use their nonprofit status to get access to way better interest loans to finance a lot of this also. So, you know, the thing, and I think there's a lot of parallels to be drawn with college today too, where you have a lot of these universities, et cetera, who spent a lot of money on these high CapEx parts of their business, like new buildings, facilities, new machines, et cetera, all that kind of stuff. And now they still have to pay for that kind of stuff. But to do it, basically, they're just kind of building bigger and bigger so that they become one of the only players in town. And the demand is sort of inelastic from the consumer side where, you know, let's say you're in, I don't know, like Ohio, like if someone told you Cleveland Clinic is not in your network, you're probably not going to choose that plan. So now you kind of have this like very inelastic demand from the consumer side. And so hospitals know they can take advantage of that to sort of do what they want, essentially. And that's not to say that, like, just to caveat this, like hospitals and teaching hospitals especially, they provide a lot of valuable public stuff. So teaching, research, all this kind of stuff, which like maybe would get kind of lost in a totally for-profit version of the business. So I don't want to say that it's like all negative, but I think a lot of hospitals abuse parts of their nonprofit status to basically become massive players in their geographies. And so one of the things I'm looking to invest in is, if you were to think about how hospital networks get unbundled, what does it look like? And that can be unbundling different service lines from the hospital itself. There, hospitals treat a lot of different diseases. What would happen if you built a full disease care delivery system outside of the hospital? How would you make it easier for physicians who are high value to leave a hospital if they wanted? How could you make, for example, more national provider networks so that instead of only competing with your local geography, hospitals were forced to compete across the rest of the U.S. So there are a lot of, I think, wedges and angles to making unbundling the hospital, but I just think it has to happen if we actually want healthcare prices to come down.
Totally. Are you seeing startups target college students in really interesting ways, or is there sort of a request for startups as it relates to the college opportunity?
Yeah, I mean, I think for college the real big thing is mental health. It's not, I think it's not like a wishy-washy check the box thing anymore for a lot of colleges where they feel like they want to have to do the bare minimum for college students. Like a lot of them are actually investing very seriously in mental health or working with mental health companies to provide, to basically provide services to their students. So I think mental health is definitely one. But I've always been a believer that really college students are this very strange population of people that leave the geography for their parents in a lot of cases, are actually going through a lot of unique healthcare struggles because it's their first time kind of leaving home, whether that's mental health issues. It's also like, infectious disease broadly. There are a lot of, college particular healthcare issues that I think make it actually a really interesting place to start a relationship. I've sort of talked about this in the post I wrote, but, a lot of tech companies have figured out that if you target college students with really cheap versions of their products, they become really sticky over time because they kind of build their own preferences. They have like a history within the product, et cetera. And healthcare companies have sort of just completely ignored this for the most part. And I understand why. College students also don't pay a ton out of pocket, and working with college health insurance plans has been like historically a nightmare. But right now, I think you have the first real wedge happening because, first of all, a lot of students are at home. So now you need to be able to offer health services outside of your campus. And then two, right now, there's like a lot more loosening of being able to practice across state borders. So doctors in one state don't need to get a license to practice in another state. And that makes it easier to have like basically keep a continuous relationship with a college student from while they're with their parents to when they transition to college to when they transition out of college. So you can actually build longer lasting relationships with these college students through that transition period in their life. I think college is sort of, it's one of those times where most people don't really think about their healthcare. I mean, you're young and healthy. It's not something you, I think, spend a lot of time thinking about. But for the first time, people, students are basically getting tested all the time. Like healthcare is a very regular part of their lives. So you can actually use that as a wedge, I think, to build better healthcare relationships with these students, even beyond just COVID testing. So, I'd be curious to see companies better think about college as a potential opportunity.
One of the topics that you weighed in on was randomized controlled trials, partly inspired by the beef that Keith Boy and Zach Weinberg had. I was just curious if you perhaps are trying to make healthcare more accessible by starting beefs of your own anytime soon. Most people were excited about the beef, but didn't really understand the topics underlying it. Why don't you shed light on sort of the two sides of the debate, depersonalizing the beef a little bit, but just what were the perspectives and what merits you both have?
Yeah, so I'm really looking for the Tupac to my Biggie in the healthcare war. So like, if anyone wants to start that beef, I'm totally down. But you better come with it. So I mean, the premise behind said internet beef was just the concept of randomized controlled trials. Like, why do we do them? Why are they sort of considered the gold standard to test new therapies and new drugs, new medical devices, etc. Versus why don't we just release these things into the wild and then kind of see how, assuming that they're safe, of course, but release them into the wild and see if they perform well, and then take that evidence from the real world application of them, and then decide basically if they, if they are better than whatever the normal treatment is. And this is actually, I think the internet version of this got into like a lot of extremism, but this has been a debate for a pretty long time. It's not something new. It's, randomized control trials, which is when you have a control arm. So, for most people who I think took science in high school, they probably remember this, but it's just like you have something that's a control arm, and you have something that's an experimental arm, and the people in the control arm basically shouldn't know that if they're getting the treatment or not, and the people who are giving it to the patients shouldn't know if they're getting the treatment or not, and that way you have a double blind. And the reason this is important is because in the real world, if a doctor, for example, thinks you're really sick, they might be more likely to prescribe you the experimental treatment because you're sicker, so it's probably worthwhile trying, and that skews the results, because then what happens is you have really way sicker patients getting the treatment, so they're going to look like they improved way more because they started from a baseline that was much sicker. So you need to have a truly kind of optimal trial design. You need to have everyone be blind. You need to have it totally random in both buckets to ensure that there are all kinds of people that you're testing it on, and you can compare them. The thing is that like that's all theoretical. In the reality of the situation is that it's very hard to get perfectly randomized buckets. It's very hard to recruit enough people into a lot of these trials to test with large enough sample size. A lot of people talk about how clinical trials, they a lot of times don't recruit enough patients just to even run the trial at all. And a lot of the big reason to that is because you have to recruit to 2 arms, and those 2 arms have to be very specific in terms of the kinds of people that they recruit, and you want a diversity of participants, and that can be really hard to get. So, the theoretical things that make a randomized controlled trial great are also the things that make it so hard to run in practicality. So the opposite of this is basically using more data from the real world to inform decisions on whether something works or not. And the problem with that is obviously the inverse of everything I just said, where physicians have their own bias on the kinds of things that they give to people, and things are, you could also just see a lot of patients who maybe are more willing to try it because it's kind of their last ditch effort, et cetera. So you really, but the benefits of having a real world trial are that you can get a much larger sample size, way easier to sort of enroll patients. And so there's some best of both worlds here. And actually, if you look across different therapeutic areas or disease areas, et cetera, there's like different kind of, just like they kind of lay on different parts of the spectrum of like how willing are they to maybe use a control trial to answer some questions, and then a real world trial to answer others. So, my general rule of thumb is for diseases where there are less treatments on the market already, and the downside of those diseases is really high, you're probably more likely to get the drug to market as quickly as possible and then see how it works in the real world. But for I think the COVID vaccine is probably a good example, actually, where the vaccine is going to be distributed basically to everybody. So the bar that we need to set for what we're comfortable with and how it impacts people has to be really high, because the potential downside impact at that scale is so devastating if it goes wrong, that like we really do need to like run good randomized control trials to ensure at least safety. And then, if we want to test things like efficacy, they're different. They're a lot of these companies are trying different versions to test that, but the bar for the vaccine has to be really high, just because of how devastating the downside effects can be. So anyway, I think there's a lot of nuance to this argument that gets lost when you try and talk shit on the internet. But I think the general debate between large real world evidence trials versus very well designed randomized control trials is sort of like as long as time itself, basically.
Maybe you're the kumbaya leader that this beef needs.
I know exactly. I'm trying to unite the sides to think of science.
Another thing you've written quite a bit about is digital therapeutics, and I'm curious how you approach that as an investor, but also just as someone analyzing and observing the space, how you sort of make sense of the excitement there.
Yeah, I think that after I wrote my thing on digital therapeutics, I think I got the most beef started at that point. So that's always my favorite topic. I don't know, man. Like digital therapeutics is kind of, I think the definition keeps changing. I think people focus too much on the definition. I don't think the definition really matters that much. I think, but personally, I know a lot of other people disagree with me. It's really, can you use software to achieve some outcome that looks similar to a drug or has a really defined thing that's measuring that it can impact. So if you're trying to monitor things like weight loss or, A1C levels or cardiovascular risk or whatever, if you can use software to nudge people to get people to do these things, great. Like you have sort of like something that looks sort of like a drug. I think the problem is like a lot of these digital therapeutics companies, a lot of them kind of look like telemedicine companies, and they kind of just look like apps. And I think the reason people try to turn them into like drugs, like make them look like drugs, is because they're trying to retrofit into this old system where they get prescribed and they make a ton of money because they can charge way more. And I'm in the camp of this all stems out of a pricing of like how we reimburse things problem. If we reimburse these things so that we reimburse it closer to what the outcome they're trying to achieve is, you would see you would see them basically look more like an in-between or like a telemedicine company and not really worry too much about how they're defining themselves. There's a lot more nuance to it. I think there's a lot of interesting stuff with how these digital therapeutic trial designs work. I think there's a lot of open questions on how should digital therapeutics basically be evaluated in the real world? Like how should their software updates work if they drugs stay relatively standard when they enter the real world? This software doesn't. It changes. It gets updated. Like, how should we be evaluating that? So I think there's a lot of nuance to the digital therapeutics topic, which, I encourage everyone to go read the post and then come hit me up, and I'm happy to, start more beef. But I think it's just like a topic where people get so hooked up on the definition rather than the fact that this is actually this is like a very indicative problem of how like poor pricing in the U.S. works. That I think we're losing sight of the issue, really.
Totally. Let's go back to EMRs for a second, or EHRs. Are you unlikely to invest in companies trying to innovate there, or how do you sort of look at the space?
Yeah, I don't know. I struggle with this one a lot. I would have said that if you tried to start a new EMR company, that you were probably dead on the water. And I still sort of believe that if you're trying to go head to head with like if Epic or eClinical Works or any of the large players, you're probably not going to do too high. That being said, I think there's kind of some interesting wedges that are popping up now. I think for one, there are companies that are basically like picking really specific so there are companies who are working in like the cash pay space, for example, or the Medicare space, where because they don't have like the same rules around how billing works, they can build their EMRs very differently. So companies, I don't think it's a standalone company per se. I think this is probably just like a feature or a product within larger companies. So like, companies like Iora, which are Medicare Advantage primary care companies, are building their own EMR because they can build something that looks very different from the ground up. Or I'm sure a lot of these cash pay pharmacies are building their own versions of EMRs that also look very different. So you're picking a wedge that looks different in terms of how billing works. And that's one way I would say I would be interested. The second is there are a lot of, for people that don't know, you can, as a patient, you can request your health records whenever you want, really. And you can give access and authorization to whoever you'd like. The problem is that it takes a really long time in a lot of cases to like get access to all of your records. For a lot of times they're not standardized the same way. And it's hard to like push that data to another service provider. One of the things that is changing is there is some regulations kind of being passed and implemented over the next few years to make these systems more interoperable. And what that means is like a lot of these EMRs have to keep their records in a sort of standardized data format so that when patients request it, it's kind of easy to move from point A to point B because it's all in one standard. Again, it's some more nuance to that, but there's never been a better time to try and build a patient-initiated data exchange. So me saying like, hey, I want my data and I want to be able to move it to whoever I want to. If you find interesting use cases for that, I think you basically you can build a really interesting business that's a little bit more patient focused and gives them the agency to take their data wherever they want. It's funny. I actually got a COVID test, I think like 2 days ago. And one part of the COVID test is that they give your health records through an EMR portal. And so if you want to see the results, you have to like log into the EMR or set up your EMR password, et cetera, and like go check it. I don't think there are that many times of life where I've ever had to like log into my EMR. I just don't see the doctor that much. So, but now with COVID testing, with a lot of these things, force people to open their EMR, regularly, depending on, I guess, where test results are being displayed. You have people who actually have to know their EMR credentials and like know their login and actually interact with their personal health records. So it's kind of like one of the few times where I've ever been like, this is interesting. Maybe people will actually want to see their health records frequently going forward. And I don't think I would have said that at any point pre-pandemic. So that's actually, I think, one thing that has changed for me is I think COVID has actually provided a wedge where people want to look at their health records a little bit more regularly.
Talk about the blog post you wrote, should social determinants come from payers and providers? What were you trying to get across there?
Yeah, so again, for people that don't know, social determinants are kind of all the non-healthcare stuff that contributes to your health. So your housing, your food insecurity, job security, all the things that kind of make it difficult for you to either access care or impacts your care down the line, et cetera. And the trope has always been like, oh, like we should be caring more about social determinants. And like, that's actually like the best way to kind of combat disease down the line. And I don't actually disagree with any of that. But the problem is we're now relying on healthcare companies to kind of do this. So we want hospitals to get more involved in housing and food security. We want insurers to get more involved in these things. This is one of those things where it like sounds good in theory, and then when we think about it more practically, there's a lot of questions that come up where it's like, okay, how do they determine who gets these, effectively social safety net benefits? What happens if you become less sick? Does that mean that they'll stop investing in those things for you? Is that going to incentivize people to like seem sicker than they are? I think the question is just that I think we struggle with as an American society, and I think really it gets manifested in healthcare is where do we want private enterprise to basically be in charge of providing social safety net benefits, and where do we want the government to be doing that? And so, you can see a world in which someone who is a high spender in healthcare now, have these insurance companies basically focusing a ton of, resources into keeping them healthy. But at the same time, it's like, first of all, who's making those decisions on who's the quote unquote sickest person is one. Two, what happens if they become less sick? And then three also is, I don't know, I'm generally in the camp that health insurers and hospitals are not like good operators and like can barely run their own businesses for the most part. I don't know if I'd be super stoked for them to be running, housing operations and meal kits and all that kind of stuff. I think that's way harder than they think. That being said, I'm glad there's any money going into this because we can learn which interventions are most effective. Like if we discover that just investing in better grocery stores and food deserts actually has the highest level of public health impact, then maybe in the future we can, as a government or as a society, invest more in that, independent of like the private enterprise. But I just think it's a lot of questions we haven't thought too deeply about, and we're kind of just letting hospitals, insurers, and everyone kind of get more deeply involved in social safety benefits without thinking about what the second order effects are.
Talk about how you see sort of the current state of telemedicine and what questions you still have on the space or what you expect to perhaps see going forward.
Yeah, I wish I had like an answer. I feel like by the time this podcast comes out, I'm going to have a completely different answer to this question. I think telemedicine is it's super exciting. My general theory on telemedicine has just been that like it's a feature, it's not its own business for the most part. And in a lot of cases, I've been proven totally wrong about that. I mean, Teladoc is built in its incredibly good business based on just telemedicine. So, that's sort of like an opinion of mine that kind of changes up and down. I'm in the camp that telemedicine is great, but our version of telemedicine we have today is just how do we take the face-to-face visit and put it onto a video? And it's not really that effective at changing anything. I mean, it's not like doctors can see more patients that way or anything. So what I really want to see more of is companies that build more native telemedicine workflows so that basically instead of just taking the existing physical visits that we have today and porting them over, we see something that looks more native. So Livongo is a good example where, I was talking a little bit earlier about the proactive healthcare workflows, but if you see someone's glucose is sort of spiking all over the place and want to like understand why, you can now proactively reach out to them, send them some nudges, etc. And that is a very different workflow than what traditional face-to-face visit would basically try and do. So I'm looking for more companies that are building natively into telemedicine and really kind of shift what care looks like by making telemedicine like a very core part of it. So I don't know. My thesis on this is still sort of evolving. Ask me again in like 2 weeks, and I'm sure I'll have a different answer for you.
We're gearing towards closing here. Our mutual friend Ambar from Maverick asked me to ask you. He said, if you had $100 and 5 healthcare startups to pick from, what would you pick? And then we could see how that answer ages over time. He said, what are some companies you're particularly excited about now?
Yeah, I mean, I have less than $100, so this is a tough question for me. No, I mean, I think the places I'm most bullish on right now, I am really interested in the cash pay space generally. I think companies like GoodRx are really understated as a company. They have gotten physicians on board to love them, patients love them. They take advantage of this like really weird blip in healthcare, which like cash pay is actually relatively competitive space, and so I think companies like GoodRx and people that play in the cash pay space, like I'm very interested in that. The second area, which I would probably a second company or whatever area that I would probably put money in is I think that there's still a lot more to be done on the food aspect of healthcare. I can't think of a company that comes to mind immediately. But I've seen a few pitches now for this, and I think it is really interesting of how do you better tailor meals to patients who are at risk for some sort of dietary specific issue. So anything that's sort of targeting food as medicine, I think is really interesting to me. A third company I would probably be interested / long on is I think companies like Butterfly that are doing Butterfly, which is a portable ultrasound company. Companies that are really like building this kind of totally new point of care diagnostic tools, I think are going to be a very integral part of the future of healthcare, especially in areas like rural areas where access to some of these more expensive machines is really inhibiting. And I think these cheaper diagnostic tools and cheaper kind of equipment is going to be one of the things that enables cheaper practices and hospitals to be built. So companies like Butterfly may want to kind of build it, especially in the imaging side of things, just generally like the stuff that's happening in machine vision right now in terms of what it can detect versus traditional specialists. It's gotten really good. So very impressed with all the kind of imaging stuff that's happening. I think Butterfly sort of encompasses a lot of that. So those 3 areas that I'm interested in. Oh man, 5. This is tough. I feel like my ideas of this change constantly. I think in general, companies that are, I don't know if I can like pick a large tech giant just because this is kind of a cop out, but I think what Apple's doing for personal health records is still super interesting. I think their stance on kind of patient privacy and make it easier for our patients to be able to retrieve their records and kind of port it over to a sort of app store like marketplace, I think will look really smart down the road, especially as they build their own devices. So, to be safe and like make sure my portfolio doesn't get crushed over the 10-year time span, probably put some money there. And then, man, last one is tough. I think an area that I am excited by. I'm trying to think of one that's a little bit more esoteric that might be different. But I actually think a lot of these public health companies. This would be like a weirder bet, but I think a lot of these public health companies are finally getting some shine. So like companies like BioBot, which are using sewage systems to basically detect disease outbreaks in different areas. I have no relation to this company also, but I think for the first time, states and cities are trying to allocate budget to deploying these companies for COVID reasons, and you can see how they would expand into new disease areas once the kind of infrastructure is already deployed. So would be really interesting to see if they can, first of all, if public health budgets kind of stay high post-COVID in response to COVID, and if companies like BioBot can ride that wave and basically expand into new disease areas and research. So those would be my five. I'd probably go 90% Apple, 10% everything else. No, I'm just kidding. But be safe. Just kidding.
Well, is there anything worth mentioning on Apple or Amazon or something you expect to be very different in the next year or two about how some of these tech incumbents work in healthcare?
It's kind of interesting to see a lot of them, Amazon specifically, kind of moving into areas like primary care. And I am always just blown away by the idea that Amazon can like deliver something to me the next day. And I feel like in healthcare, Amazon Prime is amazing because, at first it was like 2 days, and you think about all the possibilities that are open with 2 days delivery. When you move to 1 day and same day delivery, I think a lot of the healthcare opportunities really start opening up, because for a lot of people, they don't want to wait 2 days, but they can wait 1 day or less if it's really convenient for them. And I think we haven't really seen Amazon take advantage of that yet, but I would be interested. And also, they also now have a kind of real world presence with Whole Foods and it seems like they're just experimenting with a lot of stuff. I'm really interested actually to see what they do. I have no real guesses on where they're going, but it's just cool to see someone like Amazon experimenting a lot in the healthcare space. Very cool to see Google put out all of these really impressive papers on the machine learning front about disease detection and a lot of the stuff they've been putting out. So I'm excited that large tech companies are at least entering the space and getting hospitals, insurers, large incumbents like worried, whatever. I think they need to make something splashy happen, because I think the buzz of like 3 years of them saying they're going to enter the space without like any huge announcements is now starting to wane away. So I'm hoping they do something big soon.
Nikhil, this has been a great episode. For people who want to go deeper, they should absolutely check out your Out of Pocket newsletter. Thanks so much for coming on the podcast. And any plugs you want to leave us with in terms of what to expect going forward?
Yeah, totally. You sign up for my newsletter. I know everyone has one, but mine is good. Don't worry. It's outofpocket.health. You should, if you are into clinical trials or healthcare or know someone that is, you should check out my book. If You Give a Mouse Metformin, it's on Amazon. And if you're ever interested in learning more about how healthcare works or just want to jam about stuff, I'm always open. I'm trying to answer every message that comes my way. So just find me on Twitter @NikhilInit, and happy to chat.
Awesome. Nikhil, thanks so much for coming on the podcast. It's been a great episode.
Thanks, Erik. Thanks for having me.
If you're an early stage entrepreneur, we'd love to hear from you. Check us out at villageglobal.vc.